Director General NIRD-PR, Shri Rohit Kumar Sir, Additional Secretary, Mission Director, Aspirational Block Program, Dr. Keshav Rao, our Associate Professor and Head of the Center for Training and Research. On behalf of the National Institute of Rural Development and Panchayati Raj, I extend a very warm welcome to the two-day national workshop on training need assessment for refresher training program for officials implementing the Aspirational Block Program of NITI Aayog. Before we start with our session today, I would like to invite our students to felicitate our honorable guest. Felicitate our Director General Sir, Dr. G. Narendra Kumar, with a planter and a shawl. This is an August beginning of a significant milestone in the program of Aspirational Block. To mark this beginning, we would like to request all our dignitaries at the stage and our faculty to please light the diya and mark the auspicious beginning. Our dignitaries present in the dais, lighting the diya to mark the auspicious beginning of the refresher program series of Aspirational Block. Dr. G. Narendra Kumar lighting the diya. Our dignitary, Shri Rohit Kumar Sir, Additional Secretary and Mission Director, Aspirational Block Program, lighting the diya. Our Associate Professor, Dr. Keshav Rao, lighting the diya to mark the beginning of the Aspirational Block Program's refresher training series. As you know, today marks the inauguration of the refresher training programs for the officers of Aspirational Blocks of India under the NITI Aayog Aspirational Block Program. The Aspirational Block Program, or ABP, by the Aayog was initiated in 2023 to address a critical need of some carefully selected blocks from across the country. This program, as we know, stood on the firm pillars of convergence, collaboration and competition to capacitate India's 500 administrative blocks with diverse development challenges in surpassing the state average in the performance of some selected development indicators across 9 selected sectors. From the very beginning, the program emphasized the significant role of capacity building in strengthening the 3 pillars and acknowledged that block officers are the key players for achievement of its objective. It is with this commitment towards creating sustained capacities in the blocks and develop the block officials as the champions of change, the NITI Aayog collaborated with NIRD-PR and the State Institutes of Rural Development in the induction phase for training 5,000 block officials across 500 blocks. Now the ABP is reaching its 3rd year of implementation. While evidence and experience from the aspirational blocks point to improvements in institutional coordination, enhanced data-driven decision-making and increased community engagement, there are also many systemic challenges such as administrative capacity gaps, staff turnover, changed or evolved priorities in the blocks that necessitates a rejuvenation in the program. With any program, sir, I believe that the middle is always tricky because in the beginning we have hopes and we have a lot of energy, and at the end there is this sense of achievement and there is this sense of calm. But it is in the middle that we find ourselves at different crossroads. Motivations kind of dwindle, or we try to see that there are new challenges emerging. So as the ABP has reached the point where it's kind of in the middle of this implementation, I think it is extremely significant that NITI Aayog has decided to rejuvenate the block officers with a series of refresher programs. Now, the refresher training approach that we are going to take at the NIRD-PR proposed to adopt a 3-tiered delivery model, starting with a national level stock taking and training need assessment workshop, for which we have gathered here today. We have participants from across the country and sectors joining us for the training need assessment workshop, and we expect to identify block-wise priority areas for saturation, identify some of the core implementation challenges in achieving saturation in the priority areas. We expect to learn from the current experience and inform the strategy of moving forward, improved strategies for overcoming implementation challenges, integrate the insights from thematic experts to suggest solutions for implementation challenges. And we hope that through an in-depth discussion and learning about cross-sectoral integration, we would come to an understanding of the current training needs, which will further inform our module development and training delivery. Now, before I invite our esteemed dignitaries to present their side of the views with our guests, I would like to quickly take you through some of the average current status that we see and the insights that we see from the indicators, the key performance indicators, and from the data that has been shared with us. And this has been done by all our thematic lead faculties. I'll introduce them at the end of the presentation, sir. So the refresher training program, as I mentioned, that now the challenges are dynamic, new gaps have emerged, field staff are facing new realities. So now we need to reinforce the core AVP concepts and indicators. We also need to strengthen skills in analytics and data-led decision making. The plan that we have for the aspirational block is kind of looks like this, and this is what we will also do at the refresher training programs. We will do an indicator-wise gap analysis. We will set our targets. There will be a strength, weakness, opportunity and threat analysis that we are going to do. We will prepare a refined block development strategy, which will now focus on saturation of the blocks. We are going to review the strategy together with other members of our peers, and then we will finalize some plan for the block development strategies to go back and work in our blocks. As for the key performance indicators, I have clubbed them into the major sectors, starting with nutrition. As you all know, the key performance indicators were supplementary nutrition to pregnant women and children from 6 months to 6 years, measurement efficiency of child enrolled in Anganwadi centers during the reporting month, percentage of severe acute and moderate acute malnourishment, percentage of operational Anganwadi centers with functional toilets and with drinking water facilities. What we see currently is that nutrition outcomes are shaped by health, sanitation, infrastructure and community behavior. So indicators across the sectors are extremely well linked and related. If we were looking at indicators in isolation, we only look at a partial picture. So even when we are clubbing you as per your own sectors, it is extremely important that we keep talking and keep exchanging our ideas and insights with officers from the other sectors as well. Our analytics uncover patterns, causes and systemic drivers to equip blocks with tools for evidence-based planning. I will not go through the percentages. This paper is already shared with you, and you will also get the soft copy of the paper. But to quickly take you through, we see that although we have made some improvements in most of the nutrition indicators, it is still far from saturation. There is a lot of gap, especially we see a relapse in the SAM and the MAM indicators. The indicators, when we look, you see them moving together, we see that the child supplementary nutrition and the pregnancy supplementary, pregnant women supplementary nutrition, they are correlated. So they are co-delivered services. So where one works better, also the other one is also working better. Measurement efficiency and severely acute malnourished children show a high correlation, which probably means that wherever measurement efficiency has improved, we are able to capture more, and which may be one of the causes why we see that there is a relapse in SAM, because we are now able to capture the SAM children more. WASH indicators cluster and infrastructure we see moving together. SAM and MAM of course are clinically linked. Supplementary nutrition also is linked to reduced SAM and MAM, which is also tied to sanitation and poverty. Some of the root cause that we see for the nutrition indicators, they can be divided into demand side, supply side and infrastructure gaps that lead to the high malnutrition in severely acute and moderately acute malnourished children. These may be irregular take-home rations, stockouts, weak last mile delivery as per the supply side gaps. Measurement gaps could be linked to poor maintenance of equipment, overburdened Anganwadis and weak supportive supervision. As for the demand side gaps, there are caregiver reluctance, seasonal migration of women and mothers, low awareness, behavioral and cultural issues that stop some mothers to take care of the child in a particular way. There may be frontline capacity gaps, community engagement lapses, and weak data use, which can be systemic gaps. As for infrastructure, we see inadequate convergence. We see that there is weak convergence with health, especially with nutrition. There is a lack of planning in the blocks and delay in deworming, which lead to SAM and MAM children in the block level. Some of the strategic recommendation that we can provide at the moment, of course this will be fine-tuned with discussion from the block officers, is to expand child and pregnant SNP coverage, improve measurement efficiency, provide water facilities in all the Anganwadis, address the systemic leverage points are to address moderately acute malnutrition at the central outcome, invest in sanitation and maternal health, prioritize behavior change and dietary diversity, and some long-term strategy could be convergence of SEDS, NRLM, NHM, SBMG, JJM and PRIs, Data validation through field visits and community feedback could be made a practice to ensure that this works. The key takeaway from the nutrition indicators that we find is a holistic nutrition picture, behavioral and change and convergence with critical drivers, local innovations and demonstrate scalable solutions, and now we must move from coverage to quality to outcomes. Coming to agriculture, the key indicators are FPO formation, distribution of soil health cards, implementation of PM Kisan scheme, foot and mouth disease vaccination coverage, groundwater extraction monitoring. And here we see mixed kind of a performance starting from the baseline right down to the present. We see that percentage of FPO formed in total block against the total households, that has shown a massive increase nearing saturation. Percentage of soil health cards, however, we see that there is a decline. Percentage of beneficiaries under PM Kisan land details, that is near saturation. Percentage of animal vaccinated with bovine vaccination show a decline. Stage of groundwater extraction, although it is improved from baseline to now, but it is still far from saturation. Some of the block level performance issues that we want to highlight, we see that in the blocks, around 11 blocks have less than 50% coverage in soil health cards, which is why probably the saturation level is so far from here. In PM Kisan coverage, we see that 6 blocks have less than 50% coverage under PM Kisan. In FMD, we see that around 147 blocks all over India have only 10 to 50% coverage. 28 blocks have even less than 10% coverage. In stage of groundwater extraction too, we see that we have still a far way to go to reach saturation. Some of the root causes that we can discuss today are supply side and demand side root causes. As for the FPOs, there can be limited institutional support, inadequate access to working capital or financial support, shortage of trained professional to run FPOs, lack of technical guidance on operationalization of FPOs that can be supply side causes. And demand side, we see farmers' lack of awareness of benefits and services offered by the FPOs, mistrust or hesitation to work in collective models due to past failures, low financial contribution capability for share capital, poor exposure to formal markets and business linkages. As for the soil health cards, some of the supply side root causes are delays in soil sample collection and lab analysis due to capacity constraints, limited number of functional soil testing labs, poor coordination between agriculture officers and lab technicians, absence of systematic dissemination plans for test results, poor infrastructure such as labs, cold storage and irrigation. Some of the demand side root causes that we find are limited farmer knowledge on how to interpret the SHC data, low motivation to submit samples or follow scientific advice, preference for traditional fertilizer use regardless of test results, resistance to change and traditional farming practices. As for PM Kisan scheme, the supply side root causes could be delays and errors in data entry and beneficiary validation, lack of coordination among agriculture, revenue and panchayat departments, complexities in updating land records and linking bank details, absence of regular grievance redressal support. Demand side root causes could be farmers lack proper land documents or updated records, excluded farmers unaware of the ineligibility status or appeal process. There is mistrust in system due to non-receipt of previous installments or digital illiteracy. As for the foot and mouth disease, we see supply side root causes such as inadequate vaccine supply or cold chain storage facilities, lack of trained veterinary personnel, delays in procurement, poor logistic planning at the village level. As for the demand side root causes, there is lack of awareness, reluctance, lack of proper tagging and animal identification, perceived as non-essential unless a disease outbreak occurs among the farmers. Groundwater extraction management too, we see that there is limited implementation of conservation schemes, promotion and subsidy are extremely inadequate, lack of coordination between agriculture, irrigation and groundwater authorities. There is also poor monitoring of extraction levels. As for the demand side causes, there could be continued use of water intensive crops, very difficult for farmers to transit to new kind of crops, low awareness about local groundwater status, resistance to adopt new irrigation techniques, lack of incentives to change water use behaviors. In health, the KPIs, as you see, there were 7 KPIs relating to percentage of Anganwadis registered, ANC registered with first trimester against total ANCs, percentage of institutional deliveries against total deliveries, percentage of low birth weight babies in the blocks, tuberculosis cases, NQAS certified facilities, persons screened for hypertension and against the targeted population in the blocks, percentage of persons screened for diabetes against targeted population in the blocks. I'll summarize the result, and this is the national snapshot, which means this is the average of all the aspirational blocks in India. And the national snapshot shows strong coverage for maternal indicators, ANC and institutional deliveries. However, outcome gaps persist, notably, and system readiness is also lagging in many of the states in the aspirational blocks. NCD screening uptake is moderate, tuberculosis treatment success is generally very high. Correlations highlight a strong link between hypertension and diabetes screening because these are again linked services, opportunity to integrate is there in the blocks. Across KPI, we have some takeaways. We see that some of the states, the aspirational blocks are showing consistently strong in the KPIs 1 and 2. These are Tamil Nadu, Telangana, Gujarat, Karnataka, Andhra Pradesh, Uttar Pradesh and Tripura, which is ANC registration and high institutional deliveries. There are certain outcome gap despite the high coverage. For example, Kerala performs well in institutional deliveries, but there is also disease risk in Kerala. KPI 3 is also kind of a policy red flag, which is low birth weight in the state despite its high coverage. Some of the states where the aspirational blocks need a broad focus are Meghalaya, Andaman Nicobar Islands, Madhya Pradesh, Orissa and Assam, Nagaland and Ladakh. So these more details are there in the concept paper given to you. You can go through it. So there are some states where some specific focus is needed. Some common implementation behavioral challenges that we see in the health indicators is inadequate infrastructure and facilities at the blocks and sub-center levels. There is irregular supply of essential medicines, diagnostics and equipment, shortage of trained health staff and high turnover, weak interdepartmental convergence and coordination. There are gaps in monitoring, reporting and timely data entry, and we see that even when the fund is released, procurement of advanced equipment takes a long time for the officials. Some behavioral challenges are also there, such as delayed antenatal registrations due to stigma and lack of awareness, reluctance towards institutional deliveries, preference for traditional practices, limited awareness about disease prevention and treatment adherence, poor community engagement and trust in the health system, gender and cultural norms influencing health-seeking behavior, spread of misinformation in the communities, which is even more challenging now. Everyone has social media and anything kind of gets circulated as news and medical knowledge. Some supply side root causes for this could be deficiencies in health infrastructure equipment, insufficient human resources, training gaps among frontline workers, inefficiencies in data management and reporting mechanisms, limited support from higher levels of health administration, transportation barriers, inadequate internet connectivity, financial constraints, outdated equipment and facilities. Some demand side root causes could be lack of awareness or misconceptions about services, socioeconomic and geographic accessibility barriers, low motivation or trust, family decision making dynamics and social norms, belief in traditional practices and superstitions. In social development and financial inclusions, the key performance indicators are percentage of eligible households added to SHGs, household receiving revolving fund, whereas the SHGs receiving revolving fund, percentage of panchayats with digitally certified beneficiaries. And we see from the indicator performance that in the households advancing to SHGs, there is overall stability, but within the aspirational blocks, if we take the national average, we in fact see a slight decline, probably because of increase in the denominator of the calculation. Possibly the data update in locos is also at the time going on, so all the households have not been included here. In SHGs receiving revolving fund, we see a significant improvement in the average GPs with 250 plus digitally certified persons. We see moderate improvement with 10% increase from the baseline. In case of state-wise change in numbers, we see that the high-performing states which show a huge change from the baseline, these are Ladakh, Manipur, Dadra and Nagar Haveli, Daman and Diu, Andaman and Nicobar Islands, Tripura and Arunachal Pradesh. However, there are states such as Meghalaya, Karnataka, Nagaland, Rajasthan and Mizoram, where we see a decline, which probably is because locos is not getting updated on a regular basis. Some of the field observations that we have from these indicators, we see that there is delay in SHG grading due to incomplete documentation and backlog. We see there can be lack of SHG capacity, leaders unaware of the documentation process for fund eligibility, KYC not happening, lack of financial planning skills. There are banking coordination gaps, local bank branches are hesitant to process revolving funds without permission. There could be inadequate monitoring systems, no real-time tracking of pending fund cases, manual registers delays the process of releasing the revolving fund. Documentation is extremely complex with the SHGs with different formats changing, errors occurring. There is insufficient CRP handholding, There are not enough officials to handhold the CRP taking them through the process. There is also Panchasutra practice which is not happening entirely in all SHGs and which could be done through some IBCB strengthening which need to be kind of thought about in these aspirational blocks. For financial inclusion, some of the common implementation challenges are sparse of bank branches network. Banks are very far away. Shortages of the BC agents, so business correspondents are reluctant to operate in low transaction areas, and as we know the aspirational blocks already have this issue, and again getting a BC is very difficult in these areas. Connectivity and power issues are frequent in these bank branches. Female banking agents are often not available, and which creates a limit to women accessing bank in the conservative areas. There can be poor community trust in the business correspondents because people have experience of past frauds, so they may have trouble trusting the correspondents currently. There may be irregular visits from the correspondents because of the remoteness of the blocks. There is low digital literacy which also creates a difficulty in creating awareness. Some of the best practices, however, we see from the AVP blocks is incorporation of tribal households through microplanning, SHG inclusion drive in some of the blocks. We see that revolving fund as a launchpad for rural enterprise has been created in some areas, helping the SHGs set up their own enterprises. We see that from poverty to prosperity, some multi-livelihood success has been achieved in some of the SHGs. As for the banking touchpoints, a BC Sakhi model has been taken up, where the women itself, the resource person itself is there present in the community, helping people getting included in the banking system. There is also Pradhan Mantri Jan Dhan Yojana, and as for the digital network, iSaksham has been utilized, empowering underprivileged communities through digital education. As for basic infrastructure and financial inclusion, the indicators were percentage households with FHTC connection, villages declared open defecation free plus, households constructed under PMAYG, Gram Panchayat with BharatNet and Live BharatNet connection. We see that there is some distance from saturation in these indicators. Taking the overall state averages, if we see the distance from achieving saturation, and when I say state average, again I reiterate, this is average across the aspirational blocks, not the overall state. And we see that households with functional tap water connections are 84%, about 15% away from saturation. ODF plus villages about 90%, which is 10% away from saturation. Houses constructed under PMAYG, we see that it's far away from saturation at about 70%. Gram Panchayat with BharatNet also at 72%. Gram Panchayat with Live BharatNet connection about 38.9%, which is very short and very far from achieving saturation. Some of the gaps and constraints in FHTC, we see that water source scarcity is there, seasonal variability is there, pipeline network gaps in remote or scattered habitations, slow pace of scheme execution or fund release, contractors are abandoning their work after half the jobs. In ODF plus villages, some of the high performing states, and again this is average of the aspirational blocks, are Andhra Pradesh, Arunachal Pradesh, Gujarat, Karnataka, Kerala, Ladakh, Madhya Pradesh, Mizoram, Sikkim, Tripura are near full coverage. Some of the states that needs to be looked into with low performance are Manipur, Andaman and Nicobar Islands and Nagaland. In case of ODF plus, the gaps and constraints are inconsistent solid or liquid waste management systems, weak behavior change, staff and in SBMG not trained in BCC and not consistent follow-up by the staff, flood-prone or remote areas affecting sustainability. As for PMAYG, some of the high-performing states are Andaman and Nicobar Islands, Ladakh and Sikkim, Arunachal, Tripura, Uttar Pradesh and Uttarakhand, and some of the low-performing states are Telangana, Karnataka, Dadra Nagar Haveli, Daman and Diu, Andhra Pradesh. Reiterating, not the overall states but the AVP blocks within the states. Progress made by states towards saturation can be seen. Karnataka is around halfway across, there, 53.77 percentage points lower than national average. Dadra and Nagar Haveli is 43% point lower. Andhra Pradesh 33% lower. Average progress made by Andhra Pradesh was just 2.38% in fact. In Manipur during the same period we see about 35%, which is increase, which mainly comes from the Lamka South block, which has moved from just 1% in 2023 to 90% in 2085. So we definitely have something to learn from this block in Manipur. In PMAYG, some of the gaps and constraints that we see are delays in beneficiary identification and sanction process, land ownership disputes, state level prioritization differences. BharatNet, we see that some of the states that are high performers are Dadra Nagar Haveli, Gujarat, Karnataka, Kerala, Ladakh, Odisha, Bihar, Haryana, with Odisha reaching saturation already. Assam, Himachal Pradesh and Nagaland, however, are low performers, but we see a steady growth from baseline to current year. The average BharatNet connectivity shows a consistent growth, however, it starts from 70.60% in baseline, coming up to about to reach 80% in March 2025. There is steady increase, but gradual increase observed between each period, and it is approaching saturation over the time. So there is increase and about to approach saturation. In case of live BharatNet connectivity, we see that there is a substantial initial increase, jumping from just 6.7% in baseline to 25% in June 2025. Fluctuating growth after the initial surge, growth has become more fluctuating, and we see that there is a slight decline in the latest year and further decline in June 2024. But in the current year again, the growth has been resumed and the percentage has started to increase. There is also some disparity in connectivity levels. Overall, there is positive trend, but between different Gram Panchayats, there is a disparity with BharatNet and those with live BharatNet connection. Some of the key takeaways that we have from here is that while infrastructure is being laid, the activation and operationalization may be a concern. The live BharatNet connectivity, despite its rapid growth, now shows some volatility, so it needs constant kind of monitoring. To maximize the impact of the initiative, further efforts in the ABP blocks should focus on bridging the gap between physical connectivity and live operational connections, ensuring that established infrastructure translates into active and usable internet services. In case of education, we see that some of the best and worst performing states in all the KPIs within the theme. As for the percentage of boys who transition from upper primary to secondary level, there are Ladakh and I think this is Bihar, which is the worst performing state. The girls transitioning from upper primary to secondary level, again Bihar is the worst performing states. Boys transition from secondary to higher secondary level, we see Nagaland as the worst performing state, same with girls transitioning from secondary to higher secondary level. Percentage of elementary schools having PTR less than equal to 30, these are Nagaland, Ladakh, these are best performing states, whereas Jharkhand shows worst performance. Percentage of schools having adequate number of girls toilet, Tamil Nadu shows the best performance, Bihar shows the worst. Percentage of schools having trained teachers for teaching child with special needs, Himachal Pradesh shows the best performance, Mizoram shows the worst. Percentage of boys with 60% and above marks in class 10th and girls, Uttar Pradesh shows a good performance across the aspirational blocks, whereas this is I think Andhra Pradesh, which shows some of the low performances. Percentage of boys and girls with 60% and above marks in class 12 board exam, Nagaland and shows best performing states in both girls and boys. Meghalaya shows lowest performing states in terms of the girls. The correlation between KPIs and root causes and discussion of results kind of point to a few key takeaways, that there are inadequate infrastructure and resources in case of education, there is limited community participation and ownership, there are gaps in coordination among stakeholders, resistance to behavioral change, delays in service delivery or program rollout, poor monitoring and tracking system. Some of the suggestive recommendations for saturation are to help some of the indicators related to transition rate with proper tracking of students from Anganwadi to higher secondary level, and having a strict monitoring system by involving PRIs and SAGs at the grassroots level. PTR can also be saturated as it is already 74% across all the aspirational blocks. Construction of girls' toilets and schools can also be achieved if proper convergence among the departments can be established. Training of teachers to teach the children with special needs can be done through online trainings, and some already are available through websites such as Aayog and other online training portals. So this is the summary of all the KPIs. I will end my presentation here.